So, hello, good morning. We will start the first presentation about quality indicators in diagnostic echoendoscopy. I will take you through the American and the European guidelines about quality indicators and point out some differences, but also the similarities. I have no disclosures, so these are the American quality indicators. They are divided in pre-procedure, pre-procedure, and post-procedure. You can always see the grade of recommendation and also the performance target in percentage. Here you see the grade of recommendation. When it's 3, it means that it's based on expert opinion. 1C means that it's based on observational studies and that the clarity of evidence is clear, but it's an intermediate strength of recommendation. 2C means that it's also based on observational studies, but that the strength of recommendation is rather low. So the first one is the frequency with which echoendoscopy is performed for an indication that is included in a published standard list of appropriate indications, and of course that the indication is documented in your report. This should be in more than 80% of cases. Here you see the list that they publish with the list of appropriate indication, what they consider appropriate. And it's very logical. It's the evaluation of tumors of the GI tract, the pancreas, the bile ducts, and also tissue sampling of these lesions. It's also the evaluation of abnormalities of the pancreas, the GI tract, the bile ducts. There are also some therapeutic interventions, such as the placement of fiducials, drainage of pseudocysts, the access to bile ducts and pancreatic ducts, and also performing a plexus block. The next quality indicator is the frequency with which the risk associated with the echoendoscopy is explained to the patient and fully documented that they agree, that they give a consent that you can perform the examination. In the guidelines, they state that the incidence of a perforation, a cervical esophageal perforation, is very low. It's 0.03 to 0.06%. The performing an FNA introduces, of course, an increased risk, but it's still low, of bleeding of 0.5%, infection less than 1%, and pancreatitis less than 2%. They only see tumor seeding. It has been reported in a very rare circumstances, so it's very seldom. When you perform a plexus block, there can be transient hypotension and diarrhea, and of course also pain. They consider, the American guidelines consider the fact that you report your adverse events after FNA as a priority quality indicator, so they really think it's very important. And the percentage of acute pancreatitis should be less than 2%, the percentage of perforation less than 0.5%, and clinically significant bleeding less than 1%. So this is something you can follow for yourself and see how many adverse events you have. Another issue in American guidelines is that the frequency with which echoendoscopy exams should be performed by a trained endosonographer in more than 98%. But they do not state what they consider a trained endosonographer because there's controversy about this in literature. There are no clear goals. And it's not clear if it should be assessed by the number of procedures you do or if it should be competence-based, like by using a standardized assessment tool for your skills. In American studies, they often use the AUS and ERCP skills assessment tool, where you can indicate the indication of the procedure, any technical aspects, also cognitive aspects, a global overall assessment, and immediate post-procedure complications. There have been some studies about the numbers of echoendoscopies you should have performed, and they say that the trainee can achieve competence in core echoendoscopy skills after 250 cases, but of course this number varies between studies. So to conclude, there are quality parameters that you can use for diagnostic echoendoscopy. There are European and American guidelines. They clearly state some priority quality indicators. So I think it's very important to monitor these indicators. It's important to report your landmarks, to report your staging of the tumors, and to also monitor your own FNA and FNB results. Especially when you're a young endoscopist in training, I think it's very important to follow your own learning curve and to get feedback from your trainers where you can adapt your technique and like that improve your quality.
And the most important setting is that of chronic pancreatitis. With chronic pancreatitis, you can have pseudotumors, you can have calcifications with acoustic shadowing, so you can miss lesions. When you puncture, your accuracy is usually at least 20% lower than what you expect with normal pancreatic tissue. So this is the most difficult setting, really. There's also some discussion when you have a different echogenicity between the ventral and the dorsal part of the pancreas, and the presence of stents can also be annoying due to the acoustic shadowing. And autoimmune pancreatitis can sometimes be a difficult differential diagnosis to make. In those cases, if possible, you can also use elastography, contrast-enhanced EUS, and so-called ancillary techniques. With that, I mean that your pathologist tries to do extra molecular testing and look for mutations like P53 and KRAS mutations. I will shortly touch on the elastography and the contrast EUS. When you do elastography, you look at the stiffness of your mass and you try to correlate it with the rest of the pancreas. And according to the stiffness, you can make a call if it's a malignant or a benign lesion. And in some centers, they have very good results with elastography. But there is some learning curve between the centers. There is some discussion about the parameters that should be used. I don't think that it can replace biopsy, but it can be an add-on, and maybe it can help to find the correct localization for a puncture. Can I have a question?
Yes,
Arjan
sure.
Here. When you look at the parenchyma of the pancreas, do you use the Rosemont criteria, the classification?
Yes, absolutely. So we will be looking at changes in the pancreas parenchyma, be it enhanced echogenicity, ductal changes, dilation of the duct, or stones, or hyperechogenicity of the duct, to be able to already suspect the presence of underlying chronic pancreatitis. So there we can follow the pancreatic ducts, and as soon as we turn slightly more, we can see that we're at the level of the spleen. So in this case, actually a beautiful view of the pancreas parenchyma up to the level of the spleen. Now, Elena pointed out something to me that I didn't see at first, but I think Elena's correct. I want you to look at the adrenal gland. So, Elena, can you show me the adrenal gland there? So, if we look at the adrenal gland, you can see that the adrenal gland appears slightly bulky. And I think that is an adenoma of the adrenal gland. So, in this case, one would describe it as an incidentaloma of probably no clinical significance, but a small adrenal gland adenoma that one can see there.